All right, we don't have a ton of time, so I want to be sure to be respectful of our panelists who have joined us today and get started on time. Thank you so much for everyone for joining us at the summit and to our panelists today. We have three great speakers for you who are going to share their stories about organizing wins. The goal here is to share stories about local and national advocacy efforts that have advanced health equity to inform our own single payer advocacy efforts, but then to also inspire coalition building across movements. I'm going to give brief introductions. My name is Tatiana and I'll be moderating today. I go by she, her. I'll give brief introductions for our panelists, and then I'm going to open it up to each of them one at a time to give an introduction to themselves, to why they're here, what they're here to talk about, important things that they want us to know. And some of them may have slides to share. And then we're going to go through some questions that we've prepared. If you as an audience member have any questions, please feel free to drop it in the Q&A. And we'll try to save some time at the end for audience questions. Our three panelists today are Naomi Nkinsi. Naomi is a student at the UW School of Medicine, and she is also working towards her master's in public health at the UW School of Public Health. She is an advocate for centering anti-racism in medical education and ending the practice of race-based clinical practice. She has published a paper in the Academic Medicine Journal that outlines how medical education today continues to perpetuate racism and racial disparities in health. Another one of our panelists today is YuLing Koh Hsu. YuLing lives on Canarsie and Munsee Lenape land. I'm sorry for totally butchering those. That has been colonized as Brooklyn, New York City. She is the co-director for the Campaign for New York Health. She is also on the coordinating committee of the New York State Poor People's Campaign. Our third panelist is Karlynn Holland. Karlynn is a master's in public health student at SUNY Downstate, and she's a patient advocate living with insulin-dependent type 1 diabetes for 24 years since she was 12 years old. She's here today to discuss her work alongside patient advocates in the Insulin for All movement and to ensure access to insulin and healthcare is acknowledged as a human right. So to get things started, I'll turn things over to Naomi first. Go ahead and share what you're here to talk about today and about your movement, and feel free to share your screen if you have any slides.
Cool. Thanks for the introduction. So like Tatiana said, my name is Naomi Nkinsi. I use she, her pronouns, and I'm a current student at the University of Washington School of Medicine. And my activism has been around trying to abolish the practice of race-based clinical medicine. And excuse me, and when I mean by race-based medicine, it's the practice that race is ending the practice of thinking that race is a biological construct and should guide the way in which we practice medicine and interact with patients. So one example of this practice that I've been really focused on is the way in which we measure kidney function in patients. So we measure kidney function by measuring something called estimated glomerular filtration rate. And I know that this is a room of physicians and medical students, but just so we're on the same page, generally speaking, when someone's eGFR is higher, that indicates better kidney functioning, whereas if it's lower, indicates worse kidney functioning. And when we're measuring someone's eGFR, there's calculations that we use, and many of these calculations actually include race as a part of the calculation. So what this does is that when a patient is Black, it artificially increases their eGFR in a way that makes it so Black patients actually have to have worse functioning kidneys and have higher grade of disease in order to get the same kind of referrals to specialist care and access to transplants. It also impacts whether or how patients are able to access clinical trials and what kind of medications they get access to that's covered by insurance. And interestingly, it also impacts life insurance costs as well. So what I've been doing is really working with institutions, both at the university level, the lab-based level, and then also with the National Kidney Foundation and the American Society of Nephrology to work towards changing the ways in which we measure this kidney function value. And in the past year, we've seen a lot of great movement and great victories in this movement. So the University of Washington in June of 2020 announced that they would no longer be using race-based measurements of kidney function, and they would not be using the algorithms with race in them. And then kind of following that, it's been a domino effect of multiple institutions, including Massachusetts General Hospital, NYU, and institutions really across the country that have been changing their practices to the point now that the National Kidney Foundation and the American Society of Nephrology were kind of pressured by this movement to put together a task force to reassess whether race should play a role in our measurements of kidney function, and ended up coming out recently with a statement that as a whole, our healthcare system should move away from these algorithms, and they're going to be coming out with new ways to measure kidney function. So hopefully this practice will come to an end, and it seems like it's coming to an end. And now looking towards other ways that race plays a role in clinical practice. So we're learning things about how pulse oximetry is inaccurate in darker skin tones, and then things like measurements of lung function that also have race corrections built into them. So that's kind of been my area of focus, and really focusing on healthcare practices that impact specifically Black communities and darker skin communities, just because of personal ties to it and the ways in which it's very strongly linked to white supremacy and the legacy of slavery in the United States. So I'm very excited to be here and to learn about everyone else's activism and answer questions that people have. Thank you.
Thank you so much, Naomi. Karlynn, why don't you go next?
I'm going to share my screen, and hopefully my internet holds up.
Karlynn, it actually might be easier if I share the screen and you can let me know when slides should be moving, if that's okay.
That would be fantastic. Yes.
Okay, wonderful. So I'll pull it up now.
Okay. So insulin for all is a hashtag I think a lot of people have become really familiar with, especially in the last year or two. This photo is New York Insulin for All protesting outside of Eli Lilly's research offices between Bellevue and NYU hospitals. A lot of the signs speak for themselves about what's been happening to people in the diabetes community, and in particular in the insulin-dependent diabetes community. And I just really want to thank Dr. Dooley for earlier speaking to this issue and kind of preparing the audience today for this talk. So next slide. So this is me. I'm a volunteer patient advocate. I'm starting my master's of public health. I've had diabetes for 24 years since I was 12. I am the former chapter leader of New York Insulin for All. And also I did a post-bac pre-med program before applying to my MPH program. And I did a lot of diabetes research at Mount Sinai at the Stewart Lab, while working on an actual cure for autoimmune insulin-dependent diabetes. TrialNet, which does screening for autoantibodies in the blood, and the T1D Exchange, which is an open database of decades of patient information that researchers use for free to help improve outcomes in our patient population. Currently, I'm a founding board member of the New York Diabetes Alliance. I volunteer my time doing intake in the diabetes community with Mutual Aid Diabetes. I'm a district leader for the Campaign for New York Health. And I'm also a PNHP SNaHP member. And I volunteer. I don't have any conflicts for this. Next slide. So there are many forms of diabetes, which everyone here knows, especially with a physician's audience. It's really nice to have an informed audience. But I like to throw out a couple of fun facts. Half of all new diagnoses in the United States are in adults over age 20. So it's no longer juvenile diabetes. You can get autoimmune insulin-dependent diabetes at pretty much any age. Type 2 is the most common. It's 1 in 10 people in the United States, 8 million of which are best treated with insulin. And it's a common misdiagnosis with people who have high BMIs and are adults, but are actually type 1 diabetics. Just to echo those concerns about compliance. If you have someone you diagnose with type 2 diabetes and their blood sugars just really aren't falling into line, don't assume non-compliance. They may be taking their meds and they may just need insulin because they've been misdiagnosed. There are a lot of other types of diabetes. The one that is the most friendly being the loving someone with diabetes type 3, which is something our community calls our partners and family members. And then Awkward Yeti, just love this comic, though I think he's a little hard on the pancreas. The pancreas does a lot more than make insulin, but it's a cute comic. Next slide. So let's start with a group activity. What is insulin? How does it work? So we're going to do this together. So everyone just pick a food you like to eat. It could be a piece of pizza, a sandwich, a bowl of noodles, anything. And just take 2 seconds to Google carbs in pizza or whatever food you pick on your phone. Now we're going to test glucose. I do this with a continuous glucose monitor. So here's my app. I'm going to check my glucose. I scan myself like a grocery item. Sometimes it takes once or twice. And then it gives me a number. So my blood sugar right now is 148 milligrams per deciliter. That's the number we're going to use. So let's say I got that piece of pizza, and let's say it has 30 grams of carbs in it. We're going to divide that by 15 because 1 unit of insulin will cover 15 grams of the carbohydrates. So that's pretty easy. 30 divided by 15 is 2. Next, we're going to take my blood glucose, which was almost 50. We could round here. Subtract 100 from 150, you get 1 extra unit. So my total dose is 3 units. How much did that cost me? Well, if I paid retail for my insulin, which is $350 a vial at the pharmacy counter, then it was 35 cents a unit. So 35 times 3, I believe, is $1.05. So not only did I have to buy my piece of pizza, I also had to pay for the insulin that allows me to consume it and eat it and be healthy. Next slide. So that's what insulin is. That's how it works. That's what I have to do every time I eat. So let's talk more about victories for New York Insulin for All and ways that we've tried to make insulin more affordable so that people can use it the way they're supposed to and need to. S6492 was the bill that we championed through 2020, late 2019 into 2020. It had 3 parts. One is a copay price cap that passed with the budget. One is Kevin's Law, emergency refills, and the other is a drug assistance demonstration program. I'm not going to go into the demonstration program because it never took effect. But I will talk about Kevin's Law and how important that is. We also endorsed the New York Health Act, and we made COVID-19 a vaccination priority for people with type 1 diabetes by writing the letter to the CDC, testifying, and then it was picked up by other advocacy orgs. Next slide. So what is Kevin's Law? Well, Kevin's Law is named after Kevin Hochschel from Ohio. Kevin's prescription expired across a long holiday weekend. His doctor could not be reached to write a new prescription for insulin. The pharmacist didn't have the ability to sell the insulin to Kevin without a prescription. So he rationed what he had on hand, but it wasn't enough, and he died in January at 27 years old, otherwise a completely healthy person. In response, Kevin's family championed this bill that allows pharmacists very limited prescribing powers to renew certain medications. Next slide. So people talk about Walmart insulin. It's $30 a vial. It's over the counter. Why do we need price caps? Why didn't Kevin just go to Walmart? These are all valid questions that people may have. Next slide. The answer is that Walmart insulin isn't very good for people with type 1 diabetes. It has earned itself the nickname dead in bed. Whereas analog insulin really is life in a vial for someone like me. I put in some fun facts here, but I don't want to take up too much time, and these slides will be available. Just comparing and contrasting the Ration Walmart insulin made by Novo Nordisk versus the analog insulins. Next slide. So since we're with medical professionals here, let's do a little pharmacodynamics. On the left is what a normal insulin response is to carbohydrates. There's phase 1, which is immediate release of insulin as soon as glucose is detected. And then there's a phase 2 that is like a slower release from your pancreas. Phase 2 happens around 30 minutes, and that's the magic number. On the right are different types of insulin. So aspart, glulisine, and lispro, those are your rapid insulins. That's like Humalog. Regular and NPH, those are the Walmart insulins. That's what they're selling. And if we look at the peaks, you see that the rapid insulins peak around 30 minutes, which lines up really nice with that second phase. Regular insulin doesn't peak for 2 hours. So if I use regular insulin, I have to take the dose 2 hours before I eat, and then I cannot miss the meal, or I will experience severe hypoglycemia, which can be fatal. NPH must be taken twice a day, but also has a peak around 5 hours, which means you must also eat a meal at that peak or you will go hypoglycemic. When I was 12 years old, I was started on regular and NPH. I had to wake up every night at 2 in the morning to check my blood sugar and eat a snack. You don't do it, you can go hypoglycemic, and that's how people died in their sleep. So the rapid insulins really are an improvement, and they're safer for people like myself. Next slide. Just quick overview, what is insulin? It's a peptide hormone. It has to be made by a living organism. Banting, Best, Nicole, and Kollep were the first to isolate it. They sold their patent to the University of Toronto for $3 Canadian. And Banting famously called it his gift to the world, saying he never wanted it to be the source of profit. He always wanted it to be available to anyone who needed it. Next slide. These are the recombinant DNA analog insulins we use now. These are feats of genetic engineering. You'll see the difference is in amino acid 28 and 29 of the B chain. That should be a proline lysine in a human that you make naturally, but we can make these substitutions and speed up the effectiveness of the injectable insulins. Next slide. So why didn't Kevin buy Walmart insulin? Well, there's a couple possibilities. He might not have known it was an option. Education is very important. Diabetics tend to be isolated. He might have been allergic to Ration insulins, which are made using yeast instead of E. coli. Or he may not have known how to use them. As we see, you can't just eat and take insulin with the NPH and regular insulins. You must time your meals. So would it have saved his life? It might have, actually, but maybe not. Others have tried and unfortunately not survived. Next slide. So analog insulin is expensive, but it didn't used to be. When Humalog first came out, it was $21 a vial. Today's list price is $274.70. Pharmacies add on additional costs. So retail price is about $350 to $400 a vial. And on average use with an insulin pump, it's 2 to 3 vials a month. Next slide. Yep. Why do the prices go up together? Do you notice 2 insulins, same price? Well, there's only 3 insulin manufacturers: Lilly in the US, Sanofi in France, Novo Nordisk in Denmark, I believe. And all three of these companies are members of Pharmaceutical Manufacturers of America, and Partnership for America's Healthcare Future, which I know this group is already quite familiar with. Next slide. We have a rebate pricing system here in the United States. It's on purpose complicated, and it systematically inflates the cost of drugs. To stay competitive, companies must price match or price beat to have the largest rebate negotiated by the PBM, which means they are incentivized to continue raising prices over and over and over again. Everyone makes more money when the price goes up, except the people who are uninsured and underinsured who must pay the retail price, and there's always someone paying retail price. Next slide. Insulin is only one tool. I have a CGM up on the top left. That's a Freestyle Libre, like I use. You also still need blood monitoring for backup. You might need glucagon if you take too much insulin. You need to regularly see many healthcare professionals and get nutrition training and education. Plus food. You can't just eat anything. You really do need to eat a diet that works well with your diabetes, and often those are more expensive than just eating ramen noodles every day. Next slide. There are a lot of public health concerns for diabetes in the United States. CDC estimates 120 million Americans have some form of diabetes or metabolic dysfunction. It's a lifelong chronic health condition. Diabetic retinopathy is the leading cause of blindness in adults. It's also the leading cause of non-traumatic amputations, and the rate for those amputations is increasing. 1 in 4 insulin-dependent diabetics reported rationing insulin in studies done independently by Yale and the patient advocacy org T1 International. And we learned after COVID that mortality for people with diabetes was more than 3 times higher if they were hospitalized for severe COVID. Next slide. So why would anyone ration insulin? Well, it is a rational choice for survival. And I really want to hammer that in. If you run into a patient who's rationing insulin, they're not out of their mind. They're doing everything they can to stay alive within their means. So if you reduce the carbs you eat, you can reduce your insulin dose, and you can reduce the cost of staying alive, but there are limits. You go into ketosis, and that can quickly become diabetic ketoacidosis. In May of 2019, we lost 3 people under the age of 30 to rationing in just 1 month. 2 were young people of color. They each aged off their parents' insurance, and they just couldn't afford their insulin, and all of them died from DKA. Others have tried to use Walmart insulin and have not survived. Next slide. This is a page in memory to those we have lost to the high price of insulin. These are the families who were willing to speak out, to share their stories, to share the names of the family members that they are grieving to this day. On the top left is Alex Smith. He was a young man who aged off his parents' insurance. He had 2 jobs, neither of which provided him with health insurance. He could not afford $1,200 for his insulin. He rationed what he had, but he didn't make it. He died 2 days, I believe, before his prescription, before he would have had the money to refill his prescription. On the right is Nicole Smith Holt and James Holt. They are Alex's parents, and they have fought very hard for an emergency insulin program in Minnesota that is now up and running and has served more than 500 people who did not qualify for any of the patient assistance programs and would otherwise have had to pay completely out of pocket for their insulin. Next slide. Copay price caps protect some, but leave many behind. I'll just kind of leave it at that. They only apply to people with private insurance. Next slide. These are diabetes patient advocacy orgs that take funding from the pharmaceutical manufacturers and refuse to speak out in a meaningful way about the high price of insulin. Beyond Type 1 also recently filed opposition to an emergency insulin program in Maine. Next slide. Yeah, I don't like these guys very much. So here's the Insulin for All movement. It started on Twitter. It was a hashtag made by T1 International, but it's been adopted by a larger community. And the community has also formed mutual aid networks to keep people alive and prevent them from rationing insulin. Next slide. T1 International has pros and cons as a patient advocacy organization. My biggest push for them and my ask for them as a patient is that they endorse Medicare for All or another single payer or universal healthcare system in the United States. And that was my reason for stepping down as the chapter leader, was that they did not do that. Next slide. These are the next generation of organizations that are coming up, just to kind of put them on your radar. NIDA, which I co-founded, will continue to do the lobbying work for insulin legislation here in New York, and perhaps expand nationally. Mutual Aid Diabetes, who I volunteer with, meets survival needs of the community, and Open Insulin is a group of biohackers who have made their own Insulin-less Pro and would like to sell it as a generic, competing with the big 3 insulin manufacturers. Next slide. And stay in touch. I know I went a little over, so I'll yield my time. And thank you so much for giving me a platform today.
Thank you so much for sharing your story and your work with us. Next up, we have YuLing.
Oh, so I have a slideshow. Is it possible to give me screen sharing? Okay.
Yeah, I just made you host YuLing. You should be able to.
Could you try one more time?
Yeah, sure. One more time. Let's see. I think you're host now, but let me try one more time. Oh, Tatiana, I actually think you might be able to switch it. Can you make host?
Sure, I'm on that. All right, you should be able to share screen.
Okay, thank you. Okay, hey everybody. I just want to give a shout out to my co-director, Ursula Rosen. She lives on Haudenosaunee land, colonized as Syracuse, New York. Wouldn't be able to do this without her. And also a shout out to the New York State Poor People's Campaign for being such a huge influence on our theory of change and for being major partners in fighting to guarantee healthcare as a human right. So the Campaign for New York Health, we made history in New York last month. That includes many of you in this room that helped us reach that point. We reintroduced in March with majority support from members of both our New York State Assembly and New York State Senate. That's never happened before. The bill will start its way through the various committees it needs to pass before the leaders of the Assembly and Senate can bring it to the floor for a vote. And once they pass it through our 2 houses, it goes to the governor's desk. So the people we've identified that we need to pressure at this moment, and probably for the last 6 weeks of our legislative session, are the leaders of the Assembly and Senate. That's Andrea Stewart-Cousins and Carl Hastie. And we need to show them that the New York Health Act is a priority for New Yorkers, so they make it a priority for themselves and bring it to the floor for a vote. And how did we get to this point? Because this bill was introduced in 1992. And for the past maybe about 4 to 5 years, we had been 1 senator away from majority support. So how did we get here to majority support now? And how do we get across the finish line in these last 6 weeks? We love the National Union of the Homeless, and they say you only get what you're organized to take. So we organize, and we do it collectively and in coordination. And that's why the Campaign for New York Health exists. This is a critical time to show the big, vibrant movement for universal guaranteed healthcare, and that this is more than just health policy. It is about wealth redistribution and eliminating systemic extractors of wealth. It's about racial justice, economic justice, housing, immigration justice, and more. And our state capital will never be the same as we rebuild from this devastating crises, crises rather. So we have to be loud and public about how we can't have a just recovery from this pandemic without guaranteed universal health care like the New York Health Act and like Medicare for All. And also show, it also strengthens the ability to reimagine how we can all thrive in all parts of our lives as well. So the Campaign for New York Health is a statewide coalition from North Country to Buffalo to Troy to Elmira to the Hudson Valley to the east end of Shinnecock Nation in Long Island and New York City. We have nurses, and in fact, they're leading the way. 1199 SEIU and the New York State Nurses Association are our two major healthcare worker unions in New York State, and they are very close partners and collaborators with us on this movement. We have physicians, med students, social workers, home care workers, and other healthcare workers with us. We have more than 500 businesses, worker cooperatives, freelancers statewide in support of guaranteed healthcare for all. We have hundreds of political, grassroots, service, and community organizations and unions statewide as well. And it wasn't always like this. The campaign started out in 2014. The first public hearings back then were small and only in one city, New York City. And it was frankly mostly white liberals reading statistics as testimony, which was significant for that time, because again, this bill was introduced in 1992. So to even have public hearings is a major thing. But the campaign understands that we don't want healthcare dependent upon any political party or particular demographic. We want it to be dependent upon the people's needs, and especially the most marginalized. And I want to name that. I mean, for example, trans LGBTQ communities, BIPOC communities, people with disabilities, our elderly, our children, the poor and dispossessed. And the only way to do that is to build a mass movement. So we still have a lot of people missing from our movement, but we have open arms. The Campaign for New York Health has grown into a much more multi-race, multi-age, multi-faith, multi-ability, multi-everything movement. And so we got here by prioritizing moving passive supporters to active supporters. And right now we're currently prioritizing deepening engagement of our supporters. And that means organizations, individual advocates, and our legislators, statewide and nationally. This is the time again that we need everyone to be all out all the time, relating everything to guaranteed healthcare, very publicly and loudly to help inspire other people. So unfortunately, we have to do that to inspire other people to see that this is viable and it's popular, not just the right thing to do. In terms of short-term goals of passing the New York Health Act in the next 6 weeks, our priority is to get legislative leadership again to see New York Health Act as a priority. And we know that they pay attention to very few things. Their fellow legislators, they need to unfortunately see us relentless and exhausted over and over every day out in the streets, the grassroots energy. They need to see media coverage. They want to see union collaboration, and they listen to sometimes their own constituents as well. And so one way we have done that is through relational organizing, harnessing our own personal relationships to affect change. So one-on-one outreach, conversations with our friends and family to grow the size of the movement, relying on, our credibility with our own people. People who know us, trust us more. We have more credibility than, talking to a stranger. And specifically that these conversations are meant to lead up to a concrete ask. So I'll leave it there. And going back to this slide, in terms of relational organizing. So I happen to know the owners of the Cold Spring Cheese Shop here in the middle that you see. We talked about their healthcare experiences. We discussed questions they might have had about the New York Health Act. They signed the petition, have since become super advocates, have testified at public hearings, have gotten almost all of their Main Street businesses on board with the New York Health Act as well. They even designed and put up those huge window decals that you see in the slide. And they're making headway with their Chamber of Commerce. So the relational organizing, another example would be in the bottom left, you'll see Beacon's Closet. I actually happened to just walk in to the store in my neighborhood and asked to talk to them about their healthcare experiences. And then from there, it built. And then they also were like, oh, well, let me connect you to these 3 other businesses that we know. So that kind of relational organizing, it's the most impactful. Another foundation of our work is to build a leaderful movement. And another great example is in Northwest Bronx. They helped make the 2019 public hearing so successful. They were invited to a Power to Heal screening, I think back in 2017. And they couldn't make it, but they reached out to us because the racial justice aspect resonated with them. And from there, we did a New York Health Act 101 at like a big event, and then we had smaller New York Health Act 101s just with their leadership, so that their leaders could take on the work of doing the New York Health Act 101s. And they took on the work of like recording their own healthcare story videos. They took on the work of, they built enough leaders to understand the New York Health Act and how it relates to them and their communities and their work as an organization, that the public hearings, they really helped own, planning and organizing the rally and getting speakers, and a lot of the testifiers were theirs at the public hearings. And now what I love about it is that they're also talking with the Housing Justice Committee within the organization to tie together how healthcare and housing work together. So also that kind of cross movement building. And another main strategy is that our work is rooted in our stories. We've heard other speakers today speak about the importance of this. Our stories expose and counter the false narratives that justify the status quo, or that try to justify the status quo. Our stories build solidarity among one another and across differences, because again, we don't want our healthcare or any of our rights dependent upon any political party or specific demographic. We have to unite across differences. And our stories give us clarity about what we're up against and how we approach resolving it. So for example, this is Drew from Syracuse. They suffer from chronic illness. They're an essential worker. They rely on their father to remain employed with health insurance. Drew joined a storytelling training and made a sign selfie, and then worked with us to one-on-one to develop their healthcare story into a 2-minute video that for advocacy that we share on social media and with legislators and in events like this. And though speaking publicly makes them nervous, Drew has joined several speakouts to share their story in various events throughout the past year or so. And Sarah from Buffalo, another great example of moving from a sign selfie storytelling training to recording a video, and she's done lots of speakouts and she's super powerful as well. And she also has become comfortable with speaking with the media as well and coaching others to share their stories. And the last piece that I want to share today is that our work is to build coalitions, right? We can't win this alone. Our work can't be siloed. Our solutions can't be siloed. And this can mean lots of different things. I'll just talk about a few of them. We try to prioritize coalition building that's built upon political education. And so, for example, the New York Health Act did not always include long-term care. It wasn't included until 2019 when we introduced the bill to include long-term care from day one. And that was because of the work of many, many conversations between disability rights activists, elder care, home care workers, and others to have conversations with us about how, making sure that long-term care is included for them. We can't have a just like universal care for all bill without including long-term care. And so we were able to figure out how to do it the way that the most directly impacted folks need it and want it, and also still save money. And that we also support the incremental but expansive work, like protecting Medicaid, increasing health insurance coverage for immigrant communities, ending medical debt, things like that. And even though the New York Health Act and Medicare for All would make a lot of these things moot, these specific expansions and specific incremental changes, they all help us have a more robust public health system, which only strengthens our ability to pass and implement the New York Health Act or Medicare for All more smoothly. But I want to be sure that I point out, these are specific things. We don't just want to we don't want to make the ACA more robust, not like that. Oh no, this slide doesn't show up. Well, it's a picture of Audre Lorde, and she's basically saying that we don't live siloed lives. We don't live single issue lives. And for me, this speaks to me because I think everything's related to healthcare as a human right. Everything is interlocking, that decarceration is part of protecting public health. Abolishing ICE is part of protecting public health. Fully funded schools and getting cops out of schools. Even just having ventilation, AC, or heating and functioning water fountains, right? Part of protecting our public health. Defunding the police and abolishing the police, part of protecting public health. An example for that, just 2 weeks ago, the housing movement, the decarceration movement, and the healthcare movement we came together, launched a report about how our priority bills are morally right and also fiscally responsible. And we had a big press conference in person in Rochester, upstate and downstate, because our pressers tried to pit New York City against everyone else in the state. We had strong legislators, new and old, coalition partners, new and old. We had great media coverage. And further, the media coverage hardly included any opposition narrative, and that's really new. Usually in any coverage about the New York Health Act or Medicare for All, the last word, or the first and last word, is usually by the insurance companies. But we know that private health insurance and real estate profiteers are our common enemy, taking our land, closing down life-saving hospitals, denying us the care that we need, and especially in our most marginalized communities. It's insidious, simultaneously overt, vicious, insidious cycle. So this cross-movement solidarity, I think is really important. I am over time, so I think I'll stop there and we can just take questions.
Thank you so much, YuLing. So for this next part, we have some questions that we've prepared. So if each of the panelists can leave their videos on and just mute and unmute as you chime in, please don't feel the need to respond to every question. Just chime in wherever you have something to share. So our first question is, who were or are your key stakeholders in your advocacy work? How did you identify them and get them on board?
So in my work, which is based on, again, trying to abolish race-based clinical practice, I think some of the key stakeholders, or the biggest stakeholder actually, is Black communities, Indigenous communities, and other communities of color, particularly when speaking about race-based measurements of kidney function. The Black community is one of the largest stakeholders. We have some of the highest rates of chronic kidney disease, and also some of the lowest rates of being able to access transplantation and specialty care. Additionally, other stakeholders were the medical institutions themselves. So for example, the UW medicine system, the national professional organizations like the American Society of Nephrology and the National Kidney Foundation, patient stakeholders with patient advocacy support groups, and then additionally also individual physicians, and then the lab technicians that are actually running these tests, and then the EMR companies such as Epic that are actually uploading these tests for physicians to view. So I think, one way of getting them all together and involved was really taking a role in a way to form a collective movement. So I'm part of a group called the Institution for Healing and Justice in Medicine. And in this group, we involve all the stakeholders that I just mentioned in our activism. So we have right now an EGFR working group where we have talks and meetings that involve stakeholders, like the stakeholders that I mentioned, to come together, and how each stakeholder can kind of do their own advocacy work with their people, because in medicine, things are very hierarchical and people are more likely to listen to others in their specific field, but then also how we can all act together. So one of the things that we've done is write a joint letter to Congress for the Ways and Means Committee, because they had sent a request asking for ways in which medical algorithms are leading to poor patient care. So we came together to write a letter to the Ways and Means Committee to show different ways in which we can calculate kidney function that doesn't involve race, why exactly the way that we're currently doing it is harmful to patients, and what should be the next steps in funding new tests and new laboratories that can process non-race-based clinical tests at a higher level. So it was about kind of getting all the stakeholders together in one room, because they each have kind of their own strengths that they can play to, and then getting having ways that we can collaborate together. So it's not just medical students working together, but we're actually getting everyone involved. I think that was a way to get the movement from shouting on Twitter, which was originally how things started, to actually having kind of a whole advocacy network.
For Insulin for All, this sounds really obvious, but it's people who have diabetes and people who are dependent on insulin to live. But sometimes it does need to be said out loud. T1 International, when I first joined, was all volunteer, except for the CEO, who made a very small grant-based salary. And everyone had type 1 diabetes. My US leadership was a type 1 diabetic. Internationally on the board was a type 1 diabetic. CEO was a type 1 diabetic. Then they got grant money and they did hiring. They hired from outside the movement. No one had diabetes, and the national director had no personal connection. And it was just really disappointing. And the tone changed. The culture of the organization took a very sharp turn, and they started losing momentum. And that was one of my reasons for leaving and starting a new organization, which we have put in our charter that it must be patients in leadership positions. People who have board voting power must be patients who are directly impacted and have lived experience with this as an issue. None of that is to say that allies aren't welcome or invited. It is just to say that there is a preference to give platform to the people whose lives are on the line.
All right. Unless YuLing, you want to chime in, no pressure to. We'll move on.
No, it's okay. I think we covered it.
Sounds good. Yeah, and some of these questions you may have covered in your original little spiel on your movement. So next question is, what is something that you've learned through your advocacy and activism work that you wish you had known earlier when you were first getting started?
So one thing I wish I had known earlier was the type of emotional burden that a lot of advocacy work takes. So speaking from my own experience, I began kind of being more vocal in medical school, and in my Seattle class, I'm one of 3 Black women in my class. So nothing I do is ever anonymous. No anonymous survey is ever anonymous. Whenever I speak, there's the pressure of speaking for the entire Black community or the entire community of Black medical students. And that takes a huge emotional toll. It feels like you are constantly having to kind of present yourself in a specific way that doesn't lead to others in your position having like a poor view placed on them. And then additionally, in any kind of advocacy work, particularly when it is surrounding race and, you know, being a Black woman, there's always going to be kind of this underlying misogynoir in the way that people interact with you, and the way that people interact with you, especially on the internet or even with professors and leadership people in leadership positions. So I wish I'd known the kind of emotional burden it plays on someone, and the role that mentors can have in helping you kind of guide through what can be some more sticky political situations or personal situations when you're doing this advocacy work. So what I would recommend for other people is that you really ensure that the work that you're doing isn't going to be what ends up making you burnt out, right? You want to be able to do your work, but you also need to realize that you yourself as a human being are valuable. You're worth being able to have a restful night's sleep. You're worth being able to have days off. You don't always have to engage in every single argument or every single rally. You know, you can take time for yourself as well. And that's something that I really wish I had known before going in and kind of overcommitting myself from the get-go.
These are things that kind of answer the question. They're things that I have to remind myself often, that there are many simultaneous tactics to take. It's not like there's a lot of either or, like, should we do this or should we do that? But it's like, you do all of it. And there's so many ways and methods to do that, right? And also that I always try to remember to ask the question, is this growing the movement? Because it's really easy to get swept up in like, oh, we just have to have this event and that event and this event, or we have to get this co-sponsor on board and this electoral work. But unless those are in service to growing the movement, I think they are only slightly impactful, right? So if we want to get another co-sponsor on board, yes, let's do that. That is important. But are you developing leaders to take on that work, supporting them with materials or training and just mentorship, and putting them out there to lead their own lobby meetings? Or like Karlynn, Karlynn became a district leader. So she's like taking on that leadership role and help building leadership in other people to feel comfortable to take lobby meetings. Or if you're holding an event, are you inviting new people in and engaging more deeply people already in the movement to take on leadership roles, whether it's organizing the speakers or doing tech, or even just like being in the chat, or thinking about the content, things like that. So just always the question of, okay, every decision, is this building and growing the movement and building leadership in our people?
Just yes to all of that, everything that was said. Sharing the work is so important, you know, and movements, it cannot be one person by design because it's a movement. The idea of the Insulin for All movement as it's become now, you know, we're up against these incredible lobbies. The healthcare industry and pharmaceutical industry spends incredible amounts of money lobbying, and we volunteer our time. And so the tactic isn't even David and Goliath in my mind. It's let's form the tsunami so that pharma can try to hold its arms out and keep us back. But how do you hold back the ocean? How do you stop that? You can't, you know, and that's really what we're building. Yeah, it doesn't quite answer the question, what's one thing I wish I knew? I guess I wish I knew the difference between mutual aid and charity when I first started this. Mutual aid is the community serving its own survival needs. Charity is, I'll help you out if you meet these qualifications. It often includes means testing and other exclusive clauses and things like that. Mutual aid is now like the way we go about things. We get together, we say, what are the needs? And we figure out ways that we can systematically meet them without people burning out, while sharing as much of the burden and responsibility as possible.
Thank you all. I think we have time for one last question. This is a question from the audience. How would you recommend that SNaHP chapters build coalitions with other organizations to increase our intersectionality for the movement?
This might not be well, I guess there's no shortcuts. So this might not be the sexy answer, but I think you really have to do the political education for folks to understand that this has to be an anti-racist movement, and that the work is for racial and economic justice. It's not just to pass this bill or this policy. It's not just for health. And that, like Dr. Rhea Boyd, I got this from Dr. Rhea Boyd, racism works to scatter and like disrupt families, and that health inequities are when certain populations are made vulnerable to illness and disease, and often by inequitable distributions of protection and supports, right? And so the health insurance company, for example, is just one major example of this kind of white supremacy. And that's why we fight for Medicare for All in the New York Health Act, right? It eliminates that. But understanding all these other, I guess, social determinants of health, how those all relate to needing guaranteed universal health care. I think that's how you speak to other groups and demographics and bring more people in the movement that need to be here, when that work is rooted in listening as opposed to talking at people, and understanding that, you know, I am an expert on my own story and my own experiences, and I know what I need.
Yeah, and building up on what YuLing just said, and on the message that was sent on the chat, that, you know, one thing that we need to understand is that none of these movements are inherently separate from each other, right? So in order to build intersectionality within SNaHP chapters, we have to recognize that while we all want more attention and more political power, more involvement for our own specific movements to move forward, we can't do that while also putting down other movements or pitting ourselves against them. So finding ways in which your SNaHP chapter can really come together with the other chapters of other RSOs or other racial justice groups that are at your school or in your institutions will only benefit the SNaHP chapter, SNaHP as a whole, and the other groups that you're working with. There's a lot more power when groups work together or versus when they're kind of fighting each other for the main stage. So finding ways in which you guys can bring your groups together for joint organizing will be one way to be more intersectional. And also, I would encourage you to look at the leadership of your chapters, look at the membership of your chapters. If you're seeing patterns where, you know, the people that are leading these groups are majority white, majority able-bodied, majority cis, you really need to identify that there's an issue there and that there's a reason why other groups aren't joining. So my own school, we had a Students Against Racism group. And when people began to realize that the people leading these groups were mostly white, cis people, there was an inventory that was done to see, like, okay, why don't we have more Black and other people of color leading a group about racism? And the reason was because these groups didn't feel welcomed at the meetings. They didn't feel like it was based in actual anti-racist practice. So if you're noticing these types of patterns at your own SNaHP chapters, you really have to think, what are we doing wrong in not welcoming these other groups, not blaming the groups for not wanting to be there? Hopefully that makes sense. I want, you know, these chapters to take more of an introspective look.
I think a great perspective, just to build on this, that can help guide you towards a truly welcoming environment, is to remember that we fight for Medicare for all, and we will get it because we will fight for it and we will organize and we will not stop until we get it. And when that day happens, yes, we have won, but that is also the day that true work begins, right? And I think there is this mentality, and I see it with other advocates with Insulin for All, like, we got a bill passed, and they were like, great, our work is done. And I was like, no, we got the door open, our work is just starting. Now we need to lower the copay price cap. We need to abolish the copay price cap. We need to continue to tell our stories and feed them to the campaign, to New York Health, to Caring Majority, to support home care, to support access among communities. With Medicare for All, you know, it is, I also see this among some of my white organizers. They're like, this is anti-racist, this will help solve medical racism. And I'm not saying they're wrong, but I just think, like, it's desegregation. And that's a very different thing, that there will still remain incredible amounts of work to ensure that healthcare is a human right, that we all actually, now that we have access, can use it. And so just keeping your eye on that next step, understanding it's not just about you, that we all live here together. And, you know, what is really the ultimate goal? It is to ensure the dignity and the health of every human being. And these are just steps along that road.
Thank you all so much. You are all very inspiring advocates, and we're so grateful to you to taking the time today to share your work with us.